Welcome and thank you for joining us for today's HIS Talk webinar, Lessons We've Learned Since Launching Our Cancer Prevention Program. It's brought to you by Valpara Health. I'm Lori from HIS Talk and I'll be moderating. We have two speakers today. First up will be Al Bonema, MD, who is the Chief Medical Information Officer at Kettering Health. Joining Dr. Bonema will be Chris Yupa, who is the product owner for oncology services and cancer prevention, also at Kettering Health. And with that, I'll turn it over to you, Dr. Bonema.
Well, thank you very much. I'm very thankful that we could be here and join the talk today, and thank you for Valpara to bring this to opportunity. And I'm very thankful to we'll be able to introduce Chris Yupa, who will do the majority of the presentation and his outstanding work that he's done at integrating our Epic and Valpara in our cancer service line, oncology service line. Kettering Health is in the Dayton area. We extend basically up to central Ohio on the west and down to the Cincinnati area. We have 13 medical centers, 120 outpatient locations. We have in our medical group about 700 board certified providers. Overall, we have a clinical staff of about 2,000 providers and about 14,000 employees. We also have a graduate medical education program, and we have a Kettering College. And the college educates nurses and a number of allied health specialists. Next slide.
Thank you, Dr. Bonema, for talking a little bit about Kettering Health. I'm Chris Yupa. I'm the product owner, as Lori said, for oncology services and cancer prevention. And I want to talk a little bit about Valpara and kind of our relationship. So they have the Valpara risk pathways that we're using, and as you can see here, it's streamlined for cancer risk follow-up. We're using the Tyrer-Cuzick 8 model with breast density considered in that score. So they're a technology that provides something that our EHR cannot, and that is the return of risk assessments, cancer risk, various models, and receiving those into our EHR. A little bit more about the integration. They are fully integrated within Epic. So we send a lot of risk factors out through a family medical interface, and it allows us to leverage things like MyChart for entry of data and collecting it and reviewing it. We have much more efficient workflows in Epic by doing this integration with them, and we're able to get results and really kind of follow up within our tools within our EHR. So that's what Epic is doing, or Valpara Health is doing for us as an Epic customer. Back to you, Dr. Bonema.
Wanted to go over a little bit of what we're going to talk about today. One is where are we at in medicine, and so some program goals and why this has come to be implemented in our healthcare system. We'll talk a little bit about the EHR framework, a little bit of the technical interface and integration strategy, which Chris will take care of. He'll go over how we're handling using the data for performance and using it for registries and for support of patients. So a little bit of background. Preventive medicine for years has had two types of standards. The first standards are around the specialists, where specialty societies will look at a population of patients. Usually they specialize in that area. We'll make some general recommendations on how to screen for cancer and other type of health services, what that period should look like, and things like that. And so they have a process that many times those societies go through, a lot of evidence, a lot of research, simulated experiences, and then comes down to how that recommendation. We have a second path in which we use in the United States, and that's the U.S. Preventive Services Task Force, which is then adopted by a lot of the federal agencies and accreditation bodies and insurance companies, where we look at it in a very systematic way, but we look at it with the idea of a general population. So of the normal general population, we know the studies, this research, this epidemiology, we know about the risk of cancers, et cetera. And so in this general population, we say we recommend doing cancer screening at these intervals and these kind of tests, because a lot of research shows that that is that is what we know at that current place and time. And what has happened with genomics and the addition of that data is what we've known for years is not every single person is in the general population. There are people who have very unique health indicators, or genomic ones, or family history, or some other data about them for which the general population recommendation isn't correct. It needs to either be more frequent. I believe someday we'll find that some people won't have to do certain kinds of cancer screening because the probability of their getting cancer based on genetic profile, hopefully we'll learn that someday, is very, very low. So you don't have to go through things like preps or colonoscopy and things like that, or you can reduce the frequency of a test. So that's where we're at. And this, I think, is a really exciting part in medicine, is is starting to put in the idea of, for you as a person, this is who you are, genomics, this is your family history, this is your imaging results, and now give a professional opinion on what we believe your best as you recommendations are for cancer screening in the future. And that's really what we're talking about here. This is an evolution in healthcare. It's what the journey to precision or personalized medicine looks like. These are the kind of things we'll be doing until we reach some desired goal. The tough part is deciding what tests and what frequency after you've determined a risk. And I think that's a critical part here in the performance analytics, is that the data is then available to start watching to see if we have good recommendations. We don't want to overtreat, we don't want to underscreen. We want to start learning to make that more precise. All of it is probabilities, all of it is our best educated, studied assessment. So that's the background of what we're trying to do here. This is AI, this is advanced analytics, this is what it'll start to look like, probably diagnosis by diagnosis, or body condition by condition. And what I like most about this is the way in which we've integrated into the workflow. This is integrated into our EHR. There's no going back and forth, going to different different tools. And I think that seamless integration with the evidence, with the analytics, is really those are the conditions of entry, I believe, into actually really getting good decision support and these new methods and new capabilities that are developing in healthcare. Next slide. So the goals are to leverage technology in our EHR, and we want that to happen seamlessly. We want good evidence-based risk scores as best as they are, and I believe good partner companies will continue to have specialists that will continue to enhance and improve that scores. Give clinicians tools, establish the governance. Oh, that's a key one. Putting this into practice, governance is like a condition to be able to disseminate this in a healthcare system. I think physicians individually will adopt these readily because of different areas or expertise or interest, but getting this in a healthcare system is really a whole nother challenge. Getting people to trust the data, to trust to use it, establish that workflow, and where's that fit into their practice, and then overall the resources that we are working on to establish that connect the physicians and the patients. Next slide. On our committee, governance committee, with Genetic Services Steering Committee, we have radiologists because they have an important part of the data and the expertise, the primary care providers and the breast surgeons, the oncologists, the OBGYN specialists, medical informatics, and then leadership and information systems. So we have clinical leadership involved in oversight and service line leadership involved in oversight. And so this is, these people are the ones that are looking at this and bringing this to bear. Next slide. All right, so I'm going to turn it over to Chris.
All right, thank you. Thank you, Dr. Bonema. So we'll talk about the EHR framework. So this is a little more of the technical stuff here. So Kettering Health, we're utilizing HL7 integrations between Epic and Valpara Health risk pathways to determine the risks. So in a nutshell, it works as any history or risk factors is documented on a patient within a given visit, ER, office visit, imaging visit, whatever it may be. Those factors, demographics and things of that nature, as well as any medical, personal, or surgical history, are captured, and then we interface that information to Valpara's risk engines. And then cancer risk is, the algorithms over there are calculating the risk, and then it returns those scores and recommendations via an interface for the specific model and problem. So once we do get that data, the high-risk patients fall into a high-risk registry, and from that registry, we can identify the patients that are high risk and what they're high risk for, and patients who are deemed to not be high risk after maybe some more fact gathering or update to history, they will fall out of that registry. But that allows us to really use some of the tools that we have in our EHR to monitor those high risk patients and ensure that they are on a preventative care path. So, you know, patient risk scores, demographics, et cetera, are what we mine to then deliver the analytics. This is a overview of Kettering Health's integration data flow. I don't want to spend a whole lot of time on this. You will have access to this afterwards, but this kind of shows you how data is moving through the various servers so that we can get the scores. High level, we have Epic involved. We use Sectra PACS for a PACS system. We have PowerScribe 360 for a radiologist, and then we're using the cloud of the risk pathways and the risk engine to then interface that data back and forth. One other thing I want to point out is the volumetric, not the breast density percentage, but the grade. We are currently using DICOM to receive that score from Valpara into Epic. So all of it is truly integrated into Epic. As far as the patient risk factor inputs, there's a lot going on in this slide, but this is a little example of how we're obtaining those risk factors from the patient's experience. So we can leverage MyChart questionnaires to, you know, find out some history on the patient. They can review the history that we have on file, make updates, and then we can use that information in the visit to review it with them one-on-one and then pull it into the chart as we need to, if there are any updates. And the calculation of the risk, like Dr. Bonema said earlier, we want this to be seamless. So we have in their workflows as they are going through any screening kind of process, you know, whether it be hearing, vision, fall risk, we have a cancer risk assessment portion there where they can take the history, the ethnic background, hormone history, et cetera, all the factors that go in and see which models we have available, who calculated it last, and easily click a button to run that risk assessment. In our breast centers, this is actually something we're looking to automate. So when a certain action occurs within Epic, like they've begun the exam or ended the exam, we can automate this so that the click doesn't have to be, you know, triggered. The system can do that. So we're looking into doing that as well at Kettering. And this is the visibility. So, you know, seamlessly run a risk assessment. Then we want to make it visible to the clinician to know about the risk assessment. So as you can see here, we're looking in Epic at a patient storyboard, and the patient here is elevated, and we can see the recommendations of what they're elevated for, but also some recommendations on what we could do. Maybe it's breast MRI or genetic counseling and testing, things of that nature, as well as some detail around each model and problem and the percentage and the population percentage for that per that model and that problem. We also have NCCN for cancer genetic testing, which is a combination of HBOC, hereditary breast and ovarian cancer, as well as Lynch syndrome. So the NCCN guidelines for that come into here. If the patient meets any of those guidelines, they'll be considered, elevated risk. And then once we've resulted that, we showed you what it looks like for the clinician, the provider in our EHR. This is an example of what it looks like back for the patient. So the patient in their MyChart can see the risk assessment results. They can also see the recommendations, as well as we have the opportunity to send them any kind of education and messages that we can automate through a nightly batch where we can send a message to the patient to give them a little bit more information, some other resources they could go to about genetic testing, things of that nature. So that's kind of the experience there for the patient as well. One of our quotes here from Sally Grady, who's the Director of Breast Imaging Services, she says, many of our clinical users are unaware that Valpara powers their Epic risk workflows. It's that seamless. And I want you to kind of take that seamless word and really kind of hear that, because that's what we want it to be. We don't want anyone to feel like they are outside of the EHR. They're in other applications. We want it to be seamless as possible so that we're using all the data on the patient and running their risk assessment and then being guided to what we can do with the patient to prevent that cancer from happening or catching it at an early stage. Some of the management and follow-up we have. So, obviously we're now at that stage where, okay, high-risk patients, what are we doing to make sure they don't fall through the cracks? So we've put some build together inside of Epic to utilize tools. Our nurse navigators can use things to monitor these high-risk patients and reach out to their care provider to find out let them know about the resources, opportunity to answer any questions the provider may have, and determine kind of what the next steps are for that patient. Do they want to go to our cancer prevention center? Would they like to refer elsewhere or manage themselves? So those are some tools that we're using today to monitor those high-risk patients. And in the future, we're actually going to do some development to streamline this and make it a little bit better and work more so off of a recommendation rather than, okay, the patient's high risk, but we're going to look at what the recommendation may be. So we're monitoring high-risk patients for MRI or automated breast ultrasounds, ABUS. We're also looking at recommendations for genetic counseling. So our cancer prevention center can use these tools to kind of make sure that we're following up with patients on these recommendations and closing those. So that's coming down the road for us here at Kettering. So performance analytics, talk a little bit about this as well. So by having this discrete data, so when we get these scores into our EHR, this will allow us to kind of really dive into the patient population and look at why they're at risk and look at some measures. For instance, how many patients are we evaluating for cancer risk assessment? What's the percentage of those patients that are considered high risk? The number of patients at risk for breast cancer that have an open MRI breast recommendation. What's the percentage of those patients that have an MRI breast performed versus those that still need follow-up? And there's many more measures there. And what goes into, patient demographics are in it, the age, race. You can break this all down based on all this, plus the scores to kind of look at your population and what they're at risk for. This is a screenshot of one of the dashboards we have available. Like I said, not going to go into details of all these screenshots, but it is there for you to digest later. But, just kind of calling out, some things. We can look specifically at patients that have a C or D breast density, so dense breasts, and look at their Tyrer-Cuzick score range and kind of determine, are they high, 20 or more high risk? That's kind of going to lead us to an MRI recommendation. If they're 20 or less, maybe in the 15 to 20, 10 to 15, an ABUS might be an appropriate recommendation there. So we're able to look at that kind of data as well as the percentage of the population that's at risk for this problem in this particular model. So this is a good example of why it's so powerful to have the data in your EHR so that you can use those tools and the analytics to kind of see what's going on with your population. So some of the outcomes we have with running this data. So at this point, we're over 95,000 for sure patients that we have screened in our 1.7 million population. So 5.5% roughly. 44,000 of those patients were found to be at high risk for at least one of the risk models and problems, and 46% of evaluated patients and around 2.6% of our entire patient population. So that's kind of that, we're not big numbers here, but we have 1.7 million, which means we have opportunity to run risk assessments on other patients to see where they may fall with some of the problems and with cancer. A little study here with looking at 4,600 females and 150 males at 40 or under. These are patients that predominantly are getting screened within our OBGYN or primary care. They're not getting screened in a breast center because they're not within the age range, but we're able to do that because it's in our EHR, and nearly 56% of the females and 32% of the males at that age range were found to be at elevated risk per one of those models. And when we dive deeper into breast cancer specifically, and we look at that group of 40 and under, 32% of female patients were found to be an elevated risk for breast cancer. 453 or 29% had an MRI breast performed within our network, and 5.5% of those patients developed breast cancer. 56% were found in stage 1, and 93% of those patients are still alive. So that's showing us that we're able to take this and really save lives. I mean, that's really the goal here, is to prevent, catch early, save life. So that's the power of our analytics, and we'll move into challenges and optimizations, and I'm going to hand it back over to Dr. Bonema. Oh, you're on mute, Dr. Bonema.
There we go. I think Chris has done a very good job to summarize where we're at. I think as the ups and downs of a healthcare system, staffing sometimes is a challenge, and getting the best people to staff things. And genetic counselors are in high demand right now, and we unfortunately lost a really good advocate in January, and so we're working on restaffing that. Hasn't changed the governance, hasn't changed the program and the purpose, but I think putting it into full deployment, implementation, adoption, marketing it as a service does slow down that part. I think looking at creative ways to get that genetic counseling is something that is also on the table. I think we also have some awareness for some physicians to know that there is risk assessment ability in the EHR, and some of them specifically early in their career are bringing what they did in their prior training, their prior fellowship, and so they're running risk assessments outside of the EHR environment, which they're perfectly allowed to do. They just end up having to toggle back and forth and entering the data twice. I think the probability of data entry error goes up when you do that, but there's other good risk assessments that can be used. I think the beauty of what we've done here is that the data integrity is there, the data transferability is there, the integration of the workflow into the note is all in place. I think the next really big area is in taking these at-risk people and creating a system to do the follow-up, and that's just something I know we're actively doing. I was in discussions this week about what that would look like and where that would occur, and that would be personalizing the referral or the process of I think what I call the tickler system sometimes, being able to let people know that you were at risk, and this is the recommended follow-up time, and here's how to get a hold of us, and here's how to make the appropriate appointments. So I think those are the program challenges, but in terms of the seamless integration, the data, the analytics, that part is usually, that's the hard part. So the hard part's done. Now it's I think for us it's the challenges with post COVID and staffing and things like that, like other places. Program optimizations, I touched this. The Cancer Pavilion and the Reopening Cancer Prevention Center is moving forward for us. That was one of those areas not necessarily prioritized to maintain open during COVID. The continuing to work on genetic lab opportunities and partnering with other point of care counseling and testing services. I think we're very open to that. Our ability to move data and our ability to receive information, integrate things. Very confident in Chris and his team's work. The next part I think is really going to be interesting. I know Epic Genomics module has been released. It does do some things where we can take the genomic variant results in a larger scale, give a different view of it, incorporate some other apps and data feeds into this. So we have that in our modernization path in the future. And then the next big one is then getting the 2 full-time employees to help monitor and resolve and based on the recommendations for the Highrisk to make sure we don't have any care gaps and people are getting what the best recommendation is. Next slide. I think some of the lesson learned. The maintaining a staff of subject matter experts. I've been very pleased with our continuity in here for the most part. The working on the physician engagement side and the awareness, and I think we have some good ideas on improving that in some of the new forums that have been created post-COVID. For engaging the physicians, both our independents, our partnered practices, and our staff physicians. And I think that's a key part is letting people know that it's there. I know there's people who are beginning to understand how to incorporate genomics into their decision making, and so the ability to use genomics with a level of confidence on the recommendations and have that all the technological aspects worked out is I think it'll encourage adoption. I think at this point we're at actually we'll make small iterative technology changes at this point. And I'll tell you, I don't know about many of you, it's very nice to get to a point in the maturity of a module or a workflow where you get to say, I'm just making small iterative changes. And so I think that is, that I'm actually very pleased to say that. And then the raising awareness on the analytical tools, probably more so on what the questions that can be asked of it. I think that's the key, is to know, okay, I have a question about what? Okay, what is the questions? And then this is what you can go get. And then there inevitably, when people start to understand it and use it, you'll get the question behind the question. And when I know we're at that point, I know we are on a really good path, because when creativeness and curiosity and intellectual ideas are stimulated, there will always be questions behind the questions, and we know we're getting there from some of the cancer trials and things that we're starting to join as part of our research group. Next slide.
Yeah, we're at the point of Q&A here now. I do want to add a little bit on the lessons learned there with Just so you all understand, when we've been doing this, this integration since 2019, early 2019, but we'd been working on it for, it felt like a couple years trying to get to this point, because we did have the standalone application at one point in our breast centers to run risk assessments. And we saw the redundancy, the dissatisfaction with the patient, the provider having to double document, patients being asked to think, after they just did a survey, now they're being asked some questions. So we dealt with all of that, and our goal was to get to an integration. So we've been doing this a long time. So back to the kind of, looking at what we're doing at Kettering Health in our program, it's not typically like, hey, here you go, now you have everything you need. It's a kind of a build upon, like we were talking about the small iterative changes, get yourself to, milestones and getting to a point where you're able to get risk scores and the scores that you want and validate those scores. And then what else can we do with that? So the journey of it is not quick necessarily, but sharing information like this and networking with one another, we can help each other out with getting there sooner than later.
Okay, terrific. Our first question for you, does genomic always need inputs from imaging data, or can genomic be independent of imaging?
Yes, yeah, we don't have, we are running these risk assessments, and these factors are all captured within any visit within our EHR, and those can be run independent of imaging.
Okay, thanks. Do you see this solution advancing Kettering's ACO?
Dr. Bonema, I'll let you take that one.
We're very early in starting our ACO. We're in our second year. As I think in preventive medicine, where you're going with value-based care, these are the kind of conversations that will make if you're thinking from a population health standpoint and ultimately want to precisely say what that individual needs, and here's the needs of this person, here's their risk, and to do that, I think the addition of genomic data at a point in time becomes a critical part at managing around the margins. We always have death and dying, we always have morbidity, but premature morbidity and identifying of risk, the genetic data is got to be it's going to be on our journey, and there's also going to be a lot of lumps and bumps along the way at incorporating that in. One of the projects that I worked on in the past was being able to do this in the military health system, and one of the goals was so that we would just take and get the genomic data one time per person, because by and large, I should be able to reliably use that. And I think for interoperability and things like that, I think that will be important someday to be able to assimilate their data with what their experience is in their healthcare system, and then what's happening in their daily health. All those together, those data fields really are where I'll say the nirvana of value-based healthcare is going.
Can you talk a little bit about the extent of automation on the patient side for data inputs?
Mm-hmm. Oh, sure. Yeah, we have some. So when they have an appointment scheduled, we can release a questionnaire to that patient X number of days or a couple weeks prior to that visit, which allows them to start to capture that information and spend a little time obtaining that information related to their family history, mostly trying to find out when did aunt have cancer, that kind of thing. So we do have some things like I think Dr. Bonneman had mentioned some ticklers, and they're kind of little patient engagement kind of ways of saying, hey, got something here for you. So we do that currently with our questionnaires. We're also looking to do some other things with, kind of some messaging back to a patient related to their risk assessment, and little reminders and things of that nature. So we could even see some engagement there with to-dos and things like that back in their MyChart account as well.
Continuing on that, what is the patient experience like after being identified as a high-risk patient?
Yeah, good question. So in our breast centers, we do not have staff to counsel the patient at the time. So when we run a risk assessment, they will receive the results, back in their MyChart. Their physician will receive the results to talk to them. We also hand them a brochure, depending on their risk, if they're elevated or average risk. So we hand them a brochure with some information about that and some resources we have available for them and their provider. But once they've engaged in the program, what we're doing is we're referring out typically with our Cancer Prevention Center, which we're hoping to get going, here in Q4 of this year. But at that point, there would be kind of the experience would be more with an APP, or nurse practitioner, genetic counselor to go through some more detail and the family history and run a risk assessment again and possibly get to the genetic testing part of it. We're also on the patient experience side wanting to offer services with point of service kind of genetic testing as well and counseling. So we're looking at some things within our primary care a little. To pilot some things for that, because we often find that the doctor sometimes doesn't know exactly what to do with it. So the experience for the patient typically would go through that referral or onto the next genetic counselor and starting, to have that kind of engagement. And then anything that comes out of that when they're in the program, the preventative, medicine, we'll use our EHR to kind of engage them with appointments and messaging that way and questionnaires, that type of thing.
I think in terms of healthcare delivery opportunities, we do discuss this kind of ability in terms of delivering executive medicine, employment, employee health programs, and lifestyle management programs. Because we see those as a part of our portfolio of our ACO or value-based care, and looking at doing more to prevent versus than treat and receive. So I think this kind of ability ends up being in the discussion. Well, do we put that in the suite of things that we offer? Do we do that as a menu item? How does that look like? Is it in the best interest of the patient? Do we have enough evidence, for doing this that it would be worth people's while to do that? There's a lot of it's fortunately the conversation's not as complex as it used to be. It's getting a little easier to have those conversations. But I think those are the kind of conversations probably many people here in health systems are also having.
Do you find language to be an issue in this process, say for non-English speaking communities?
We do have the ability within the MyChart of sending questionnaires in a different language. So I believe that we have that set up to where from different Spanish folks can get that in Spanish versus English. I don't know how much of I don't know how often, but we do have the ability to do that in different languages.
Okay. How important was it for you to not deploy standalone solutions for risk assessment and patient management?
Well, when we say standalone solutions, I think we're thinking outside of our EHR. So, like for instance, we had the application of what Valpara had before, and that kind of led us in our organization being the size it is, and it's really kind of a lot of redundancy. So we didn't want to dissatisfy the patient or the clinicians capturing that. So using a standalone kind of system outside of our EHR was not something that we we wanted to do. We learned from that pretty early on, years and years ago before we did the integration, that even in a breast center, that's a pretty painful process for everyone. So it's very important for us to not use standalone systems.
Let me speak to that, because usability for me is probably my #1 trait or a characteristic that I'm looking for. The statistics and over the years are really, really clear, and that when you have multiple applications or when you don't have integration, the probability of implementing and adopting it goes down significantly. And what you end up doing is you see this great idea and it just never really takes. And this happens over and over and over, all over the place. And so I haven't come out and just explicitly said that we'll never have another application that is not integratable, but it is. If it is, my first question is usually cybersecurity. My second question is can I embed this into the workflow of our caregivers and our clinicians? And if the answer is no, I'm probably pretty discouraged about it at that point.
Okay, next question. Did you have any providers already offering cancer risk assessment before the system-wide approach was identified? And how did you manage the change to this approach?
Yes, the answer is yes, we did, and we still do. So it's kind of an ongoing thing with back to marketing and education, and making them aware that they can do these things within the EHR. But yes, we still deal with that. Not initially before we've heard of several applications being used, from freebies to things that were being paid for. So we had other technologies and other security things we had to look at with those doctors running risk assessments outside of the EHR. So we wanted to eliminate that as much as possible, and but it is an ongoing kind of battle, if you will, that we're continuing to educate and communicate that we have these offerings, these services within our EHR, and they don't really need to use those.
Okay. How do you deal with discrepancies in risk scores or provider disagreements?
Yeah, what the nice thing about the Cancer Prevention Center was that was another resource for providers to go to discuss, those questions about some of that. As far as discrepancies go, if they're, I think part of it is understanding how we're using the models and such. A good example would be Tyrer-Cuzick. That model, do you have breast density, in your factoring on the freebie, or do you have competing mortality turned on or off, things like that. So we run into some of that where they might be running it through IBIS or something like that, and they don't have competing mortality on, and they'll say, hey, they're not high risk according to what I'm doing. How come you're saying they're high risk? So that goes back to what is our program, being transparent with them, the models we're running, the thresholds we have, what's going on with those to deliver those results. And so we handle it that way through the Cancer Prevention Center. We also have the ability to reach out to Valpara Health. They're very helpful when it comes to some discrepancies where they can take a look at the factors that were involved and kind of help us find any of those discrepancies if there is any, and explain it. And so we leverage them quite a bit as well.
Okay, terrific. Well, that was our last question. So with that, we'll conclude the webinar. Thank you to everyone for joining us today, and thank you, Dr. Bonema and Chris, for the interesting and an informative presentation. We look forward to seeing you at our next HIS Talk webinar. Enjoy the rest of your day.